Comment allez-vous? Ça va? Bienvenue. And that's where we are, maybe French 101. Welcome, clinical problem solvers. Today is another RLR session. Very excited. Robbie's going to be here a little late. Aiza, ça va pas mal, comme si, comme ça. We need a case. So if anyone has a case, please put your name in the chat. Ideally from someone who hasn't presented yet, but anyone. And as we're waiting for the case, maybe I can have Shema and Mukund introduce themselves. Shema's teaching today, and Mukund is scribing. Mukund, maybe you can start first and tell me, am I mispronouncing your name, or how do you say your name?
No, that's quite good. It's Mukund.
Tell us a little bit about yourself.
Sure. So I'm Mukund. I just finished my first year at UCSF, medical student. School starts for me in a week. I don't know much about medicine, so I will tell you about stuff that I do outside of medicine. I play the Indian classical violin, and I'm a deep sky astronomer and astrophotographer. So ask me about space.
Wow. Mukund, that's so interesting. I can ask you a million questions. I am quite ignorant. Everything I know about space comes from the Big Bang Theory and Sheldon. But question I have for you. So you're a first-year medical student, is that correct?
Yeah, I just finished my first year, starting my second soon.
I don't think we have anyone who's as young as you in their training, which is such a great sign. Because if you're starting now, what will the future look like for you? It would be pretty amazing.
Yeah, I look forward to finding out. This has been so much fun. I'm happy to be here.
Listen, just don't take my job. I'm joking. Shema, unmute yourself and tell us a little, maybe you can tell us about yourself, because I think everyone knows you in German.
In German? Okay. So I should speak in German. Okay. Hallo, ich heiße Shema und ich bin eine Studentin im 5. Jahr und freue mich total, hier dabei zu sein. Und as a conclusion, I would also like to say something in French because I forgot a lot. So, je m'appelle Shema. Je suis dans un library. I forgot the word for library. Yeah. And I'm happy to do the teaching point today.
Shema, je peux vous tutoyer? I'm sorry.
Can you repeat it?
Oh, so basically, you know.
Bibliothek.
No, not bibliothek. No, the issue is that not the issue, but in Iran and in France, I guess when you say you, the formal versus the informal is really important. And so then I was learning how to say, can I call you in the informal, friendly way? Tutoyer?
Mais oui.
Oh. Bien. All right, that's your French lesson for today. Do we have a case volunteer? Oh, David, please unmute yourself. Of course you can. We would love for you to present. Tell us a little bit about yourself. How do you pronounce your first name? Where are you from? And what is your language? What's your first language?
Hi, I'm David from Madrid, Spain. Spanish is my first language. And I haven't been speaking English for a while, but if you want, I can present today.
Your English is so much better than my French. And is it David or David?
David. David, yeah.
And most importantly, are you a Barcelona fan or a Madrid fan? Or a Getafe fan? Maybe you like Getafe. I don't know.
No, Madrid.
Madrid. And who's your favorite player on Madrid?
I think the best player in Madrid is Modric.
Oh, they asked a good question. So you're Real Madrid or Atletico?
Real.
A very good team to be part of. All right, everyone. Well, thank you, David, for volunteering. I know how intimidating it can be presenting in a second language. So we really appreciate you, and just take your time, and we're really happy to have you. If we can take over the screen, Mukon, for scribing, and Shame is going to be doing the teaching point. So David, whenever you're ready, please present.
Okay, so this is a 68-year-old man who came to the ID with back pain. And if you want, I can explain a bit more.
Oh, great. So that, David, you said it came with some chest pain, yes?
No, back pain.
Back pain. Back pain.
Yeah.
Got it. Yeah, please tell us a little more.
Okay, so this was a 68-year-old man who came for complaining with back pain since 2 weeks, and which he attributed to a recent hospitalization he had for when he was admitted for severe hypokalemia. And he denied chest pain or palpitations, no fevers, no chills, no night sweats. He hypokalemia, and he admitted to have some mild dyspnea, and no cough, no sputum, no edema. And if you want, I can give you the past medical history, or
No, David, I think that's a perfect stop. Can I just ask you one question? How low was the potassium?
2.1, I think.
2.1. Okay. Wow. What a case. Okay. Folks, we're going to talk for 2 minutes about back pain, and then we're going to talk about hypokalemia. And when you see both these findings, I want you to say in the chat, which one will you focus on? If the patient comes with the potassium, hypokalemia, and back pain, which one would you focus on as your anchor point? So for back pain, just a brief overview, and I'm only keeping it brief because the main issue here is the potassium. Now, the cause of hypokalemia may also explain the back pain, but we have to put all of our energy on that potassium, and I'll tell you why in a moment. When it comes to back pain, for those people who have their video on, who has experienced back pain in their life? Thank you, thank you, thank you. Yes. This is a true story, Rafa. You'll like this story. I was an intern, and I was getting ready for my call day. I walked down my steps in San Francisco, and all of a sudden I developed the most severe back pain I've ever had. So I was like, oh my gosh, do I have to call off? But as an intern, you never want to call off, because that means one of your colleagues gets called in. So I texted Gurpreet Dhaliwal, and I said, Gurpreet, I can't move, my back hurts. He said, Reza, take 800 milligrams of ibuprofen and it should be okay. I took the 800 milligrams and I actually was fine. The point I'm making here is that 95% of back pain is musculoskeletal strain, something that's non-specific, okay? If you were a betting individual, you could tell almost all the patients with back pain, almost, not all, almost, that they will be fine in a few weeks. They will be fine. But when do we actually consider serious causes of back pain? Folks, when you have headache, what do you look for? Red flags. So what I want you to put in the chat is, what are the red flags you would consider when evaluating someone with back pain? Because this will guide your questioning of the patient in the HPI. The red flags, one red flag that always exists is inflammation. And that is if someone has fever, if someone is tachycardic, if someone has leukocytosis when you check their labs, that's a red flag. I would not say, go home, you're going to be better. I'd be like, what are inflammatory causes of back pain? How about if someone had a focal neurologic deficit? All of a sudden, they had a foot drop. All of a sudden, they couldn't move their right lower leg. That's worrisome. So a focal neurologic deficit. How about a history of cancer? Another red flag. So when it comes to back pain, look for red flags. If there are red flags, it tells you you need to be more aggressive in the initial workup. If there's no red flag, really, most often the patients do well. But if it persists, the patient comes back. Now you got to investigate for serious causes of back pain. But back pain is not the problem here. It is the problem, and maybe relates to the hypokalemia. The hypokalemia is the problem. Here's something really important, and Ravi will agree with this. We see hypokalemia, hyponatremia, hypomagnesemia all the time. But you're missing something if you just say hypokalemia. If someone has a potassium of 3.3, are you going to get excited? Will you get excited? No, I hope not. So what you're missing here is severe hypokalemia. Severe hypokalemia. When that potassium is less than 3, boy, you have my attention. Now it's the center of gravity. It's everything that our evaluation will be about. And something really pains me here is that all of a sudden the focus isn't diagnosis. Although you will be doing that in parallel, management rises to the top. Why does management rise to the top with severe hypokalemia? Because potassium is needed for proper cellular function. Whether it's too high or too low, you're going to affect the cell's ability to depolarize and contract. This includes heart cells. And what happens if they don't depolarize or if they go into an arrhythmia? That can lead to death. So right away, this patient, management-wise, what would you do for the patient, management-wise? You'd put the patient on telemetry. You have to monitor the rhythm carefully. You would check a magnesium because in order to replenish the potassium, you need a normal magnesium. I'll tell you why that's the case, at least what I understand of it. Magnesium, when it's normal levels, it prevents the kidney from excreting potassium. When the magnesium is low, you get transcription of the ROM-K channels in the distal nephron. These are the channels that allow potassium to go down its gradient. So when magnesium is low, these ROM-K channels come in the distal nephron and you lose a lot of it. That's why we always check MAT with potassium. Magnesium is potassium's best friend. All right, so telemetry, this patient's getting IV magnesium. IV potassium, and you're checking a magnesium level. And then this is something more practical for the junior trainees in this session. For every 10 milliequivalents of potassium you give to someone, you can expect their potassium to rise by 0.1. You really can't give more than 10 per hour through a peripheral IV, but you can give more through a central line if needed. We need an electrocardiogram because low potassium, what that does to the EKG and what's concerning for it is a prolonged QTC and torsades. So we really need an EKG. Now, let me just briefly talk about how do we actually approach hypokalemia. Maybe take 10, 15 seconds and think about it yourself. This approach applies to any electrolyte abnormality. Is it an issue with PO, which almost never is the case? When I say never, it's almost never completely explained by a PO, but there are instances where it might be. Is it an issue with the GI tract? Is it an issue with the kidney? Or is it an issue at the cellular level, like transcellular shifts? But remember, folks, we always say, is it this, is it that, is it this, is it that? Why can't it be a contribution from each of these? Like a little bit GI, a little bit kidney, a little bit cellular, a little bit oral. I don't think oral would explain this. So you're focused on the GI tract, the kidney, and the cell. Now, listen, David hasn't given us much more information, but do you know that you can probably pinpoint the cause of hypokalemia just from history alone? It's the truth, just by history alone. Because think about it, what GI causes cause hypokalemia? Vomiting, diarrhea. Thank you, Rafa, diarrhea. And let me ask you this question. How can you tell the difference between vomiting and diarrhea with one lab test? One lab test will tell you if it's vomiting or if it's diarrhea. Thank you, Max. The pH. When someone vomits, they're literally vomiting acid content. When you lose a lot of acid, you become alkalemic. So in someone who's vomiting, the pH is high. And then that hypovolemia activates the renin-angiotensin-aldosterone system. And aldosterone being activated, it binds to the mineralocorticoid receptor in the distal nephron, and you get increased potassium secretion. I can continue, but I'm going to pause. Let's get more data. But these are the kind of, you want it to be hypothesis driven. The challenge becomes when someone doesn't tell you that they're taking a laxative, they're taking a diuretic. That's when it becomes difficult. But in most cases, if the patient's not vomiting, if they're not having diarrhea, if they're not on a diuretic therapy, the most common cause of renal loss, you're left with transcellular shift or kidney, because there are acquired kidney disorders that make you feel like you're on a diuretic, I'm going to stop there, give the mic back to David. And David, very excited for this case, my friend. You might convert me to a Madrista.
Okay, so I go for a little with the past medical history because I think it explains a lot. Well, since 2 months ago, he only had hypertension and low risk prostate cancer. 6 years ago, treated with radiotherapy. And 1 month ago, when he was admitted to the ER with severe hypokalemia, he ended up diagnosed with Cushing syndrome, which the origin was not founded. They did a CT, thorax, abdomen, pelvis, and Knocker scan, a pituitary MRI, and they did not find anything. And as a complication also from Cushing disease, Cushing syndrome, he had type 2 diabetes, or his meds were aspirin, metformin, and pagliflozin, enalapril, spironolactone, and omeprazole. Okay, I slow down a bit. Yeah, aspirin, insulin, oral potassium, yeah, and metformin, yeah. He was non-smoker. Yeah, he denied recent travels, no animal contact, and he denied also skin rashes. I didn't tell you that in the HPI. And if you want, I can tell you the vitals at least, because I think they can help you to focus. And the temperature was 36 Celsius. Heart rate was 76. 140, 100. The respiratory rate, I don't have it, but I think it was 20 more or less. And the SpO2 was 77 on room air, climbing to 90 with 3 liters per minute. Okay, and if you want the physical exam. Well, he was not in acute distress. He was alert, oriented, tachypneic when talking, but denied dyspnea. And cardiovascular, yeah, cardiovascular was normal. Pulmonary basilar tracker, and abdomen was soft and tender, not distended. And he had low thoracic spine tenderness to palpation, and yeah, no skin rashes, no leg edema.
What's up, folks? It's great to see you all. I'm sorry I'm a little late. I'm sure you were bamboozled by Prof. Rez. I was definitely at the end. Not just because of his poetry, but also because the very fine professional shirt he's wearing today. I haven't seen professional Prof. Rez in a while. And David, I gotta say, I've seen your posts on Patreon and your presence here on VMR, especially with your video on including yesterday. So excited to see that you're presenting your case today. And I'll just say up front that there's no chance you'll ever convert me to a Majanista, but who knows? I gotta stay a little humble. And I think that you know there's a lot of data here, and maybe I can just color in the background data and leave the foreground, namely the exam for Prof. Rez to analyze. And I didn't quite hear it because I was just finishing another meeting while transitioning here, but I heard you say Cushing syndrome. And the presence of Cushing syndrome in this patient has to be a powerful determinant of how we analyze this case because of its rarity and because of how many morbid complications can occur. But you have to do that with always one foot in the idea that you might have diagnosed that incorrectly. Diagnosing Cushing syndrome is really hard. There's no one singular definitive test. So you always have to say, am I sure that this patient has Cushing syndrome? Always. But here, if you apply the possibility that this patient does have Cushing syndrome and you see hypokalemia, you have to move quickly to a rare cause of Cushing's, and that's ectopic Cushing's disease. The truth is that movement is balanced in some respect by the fact that ectopic Cushing only accounts for 15% of all of Cushing's disease. The large fraction of Cushing's disease is actually exogenous Cushing's, meaning that the patient is accidentally or deliberately taking exogenous steroids. Okay. Now, then that is closely followed by pituitary causes of Cushing syndrome and then followed by ectopic. So we still have to be systematic in saying, what is the cause of this Cushing's? If it is in fact Cushing's, is it exogenous, pituitary, or ectopic? But the presence of hypokalemia should make you prioritize, not beyond the base rate, but prioritize ectopic Cushing's. Now, as soon as you say ectopic Cushing's, you have to ask yourself, well, what causes that? And the most common causes are unfortunately very aggressive diseases in the thorax, namely small cell carcinoma, which will become relevant in the exam for sure. But less common causes include bronchial carcinomas in the chest, as well as abdominal tumors like pheochromocytoma and pancreatic neuroendocrine tumors. There is a culprit on the screen already, and that's prostate cancer. So in patients with advanced prostate cancer that is usually androgen refractory can develop small cell dedifferentiation of their prostate cancer, and that can cause Cushing's. Sorry, I just saw that the board was updated to ACH dependent, which tells you that it is endogenous, but does not help you distinguish between pituitary and ectopic, because both pituitary and ectopic secrete ACTH. So the context of Cushing's is going to be crucial. It being ectopic or not is going to be very helpful. Regardless, the hunt is on for either a pituitary tumor as a cause or an ectopic tumor. But more importantly, before we think cancer, we have to prioritize infection as a contributory complication to this case, because this patient probably has a whopping amount of steroid floating through his body. And I'll pass the mic to Professor for any other thoughts and comment on the exam.
Thank you. You know, David, this is such an incredible case because one of the most important things that you can learn throughout your career is when to slow down. When is the most common, not the cause in the patient. And here, when that patient had a potassium of 2.1, it really should have prompted the clinicians to slow down, because to have Cushing's, just regular plain old Cushing's, to cause that, it's very unusual. It's very unusual. So now we look at the physical exam. And when we're assessing this physical exam, we're dealing with the problem of hypoxemia. Hypoxemia with pulmonary findings. The question becomes, are the pulmonary findings that we're auscultating on physical exam enough to explain this degree of hypoxemia? Or must we think about causes of hypoxemia that don't have findings on exam, like pulmonary embolus, like shunt? But for now, we know that the process in the lung is contributing. And so what can cause crackles? Well, just think of what might fill up the lung. Robbie mentioned, if this patient is in a state of hypercortisolism, what does it do to your immune system? If someone was on steroids, wouldn't you say they have impaired cellular immunity? So this patient has an impaired immune system. So you have to consider pus, consolidation, crackles. Could this be fluid? Fluid. Of course it could. Could the patient have non-cardiogenic pulmonary edema? Could the patient have underlying cardiac disease and now is decompensated? It's possible. Could this be atelectasis? Always say atelectasis because you can never go wrong. And finally, could this be cancer in the lung causing a post-obstructive pneumonia? Why would I ever mention that on aliquot 2? Because of aliquot 1. Severe hypokalemia. Robbie said that's not common in just plain old Cushing's. So now we're thinking about an ectopic Cushing's. So now we have to consider bronchiogenic carcinoma and small cell cancers of the thorax. Could that have metastasized to the back, causing the back pain? It's possible. So where to go from here? Imaging. Look at the CBC. You probably will anticipate a neutrophilic leukocytosis, 0 eosinophils, and an alkalosis. But let's see what happens. To you, my friend David. Oh,
I think you're muted.
Sorry. I start with the CBC. White blood cell counts were 9,000, 85% neutrophils, 8% lymphocytes, 0 eosinophils. Okay. Platelets 131. No anemia. Okay. Sodium 141. Potassium was 4.5. Chloride 106. Creatinine was 0.9. Glucose normal, calcium normal, magnesium normal. CRP was 5 milligrams per deciliter. PCT was normal. Ferritin was 1,500. D-dimer was 1,400. And if you can, well, ECG was normal. And if you want, you can I can hold there and you can comment what test would you ask for.
That sounds great, David. Maybe I'll just focus on the ferritin and give the rest to Robbie to tackle. With the ferritin, it's an inflammatory marker. And basically, when you have a lot of cytokines, you increase transcription of the ferritin mRNA and you see high levels. But it doesn't help you really prioritize amongst any specific causes. Even when the ferritin is 10,000, they'll tell you to think about stuff like HLH, adult onset Still's disease, histoplasmosis, hemochromatosis, the H's. But our great friend Andrew Olson showed in a paper that, yeah, you should think about those, but anything can do it. So hyperferritinemia just tells me that this patient is inflamed. Mike, to you, Robbie.
You know, I always love it when you take on things to counter the narrative. I think those are the best teaching points, honestly, to teach all of us not to overanalyze a data point. I love that that point here about the ferritin. And I think it actually also applies to the rest of the data. You can't overanalyze it because this patient has whopping doses of steroids circulating through him. Now, what am I really trying to say? I'm saying that we have to prioritize infection despite the normal white count, and we have to continue proceeding on inflammation despite the normal CRP, and we have to continue entertaining the possibility of malignancy because of the case of ectopic Cushing's. So here you can make the mistake, I think, of saying this is an afebrile, normal white count, normal CRP. This is not a pulmonary infection. But I think because of the presumed marked immunosuppression that he has, I think that would be faulty, at least initially. So I think in this case, your analysis of the pulmonary process will be informed by imaging. But early on, you should ask yourself, well, what infections should I really prioritize looking for? And the truth is the usual stuff, viral and bacterial, but a special attention to infections that are specifically steroid vulnerable. And the most notorious is PJP. Now look at this case from that lens. You have marked hypoxemia with minimal symptoms at rest and bilateral crackles. That is a slam dunk illness script of PJP, right? Of course, it doesn't mean it's PJP, it just means it's highly compatible with it. And then if you extend that list, what else could it be? It could be Cryptococcus, it could be any endemic mycosis. But a notorious steroid vulnerable infection is mycobacterial disease. So you got to be careful that this person isn't high risk of having miliary or disseminated TB or nocardia. So what would I do? I think the imaging will be informative, but early on, you might consider sending an LDH and a beta-D glucan to help you understand the probability of PJP. You might go above and beyond and send, in addition to sputum cultures, AFB sputum cultures in this patient. And you might also consider a serum cryptococcal antigen. All those tests are very helpful to help you modify your probability of pulmonary infection. So to summarize, all these funky infections are at play, but they remain low probability because we haven't proven there's an infection and we haven't proven that it's not something usual. But the tests to look for them are pretty helpful and probably indicated in this immunosuppressed host. All right, David, back to you.
Okay, so in the ER, a CT angio was done, which revealed bilateral pulmonary infiltrates with high SARS-CoV-2 probability, no PE, and ventrilobular emphysema. And well, an LDH was also done, which was 595. And the PCR for SARS-CoV-2 was negative repeatedly. And they also sent sputum cultures, which were negative. HIV was negative also. Legionella and pneumonia were also negative antigens, and they did a valve for sputum, and it was also negative. And I can pause there if you want, because I think there's one more item.
This is very, very intriguing. I will leave all the data for Prof. Resch to analyze, and I'll take on the CT findings. But may I ask you, David, when you say a high probability of COVID based on the imaging, my mind translated that to ground glass opacities, which is the classic finding for COVID. Is that accurate, or were there some nuances?
That's accurate. Yeah, there were bilateral ground glass opacities.
Perfect, perfect. So I'll just share a quick approach to that, because I think that has to anchor the remainder of our analysis. And so what do GGOs mean? GGOs do not modify the differential diagnosis that Prof. Rez laid out. We still have to say, is it pus? Is it water? Is it blood? Or is it some kind of inflammatory cells? Now, what does GGO do? It just puts a couple of caveats to that analysis. So specifically, the caveats are within the realm of infection. And the presence of GGO takes all the infections, keeps them still, but highlights 3 of them. The 3 are viruses in general, 1, specifically, number 2, CMV, which you wouldn't otherwise consider, and 3, PJP. So let's be clear. Everything is at play: blood, water, inflammatory cells, including malignant infiltration, which we had on an RLR. But within the infection, all of them are at play, but highlighted are viral NOS, including COVID, CMV, pneumonitis, and PJP. So that's what GGOs does. And I'll pass the mic to Prof. Rez to analyze the rest of it.
Absolutely beautiful, Robbie. David, this is a tough case. And I'll tell you why this case is tough. When a patient presents to you with an immunocompromised state, like, let's say, HIV, do you worry about one unifying diagnosis, or are you concerned for multiple diagnoses? And that's the state that we find ourselves in here. This patient is has overwhelming steroid exposure. So this patient has impaired cellular immunity, making them at risk for common infections and atypical infections like fungi that Robbie mentioned, and mycobacterial disease. The PJP hypothesis has to be taken serious here. And what's interesting about that is, what is the treatment for PJP? It's a fungus. There's usually 2 agents we use for immunocompromised patients. I know for HIV, I'm not as up to date with hypercortisolism, but not only do we use Bactrim. Yes, Bactrim is an antibiotic, and it is sort of confusing that it treats this fungus, but we also give what other agents? Steroids. And this patient's already challenging themselves with steroids. That steroids really helps when you have hypoxemia and PJP. That doesn't change my post-test probability. And the negative sputum cultures, you have to understand Bayesian theorem and sensitivities of tests. It's not 99% sensitive. It's not like a BNP and heart failure. First of all, no test is 100% sensitive if the clinical context is strong enough. But this sputum culture does not deter me at all from the diagnosis of pneumocystis jirovecii pneumonia. Ideally, you get a BAL. You get a BAL, but you have to let everyone know that you are concerned for potentially mycobacterial disease. So you have to keep everyone protected. You would start Bactrim in this patient empirically, you would. With the high LDH, the hypercortisolism, the bilateral infiltrates. I think Robbie has made a great case for it. But you would get a BAL or induced sputum, and you would be evaluating it for the direct fluorescent antibody and the PCR. But folks, we're not done yet. I still don't believe that this patient just has Cushing's. I'm worried for an underlying malignancy compromising the patient's immune system through hypercortisolism, leading to an atypical infection. So what would I honestly do next? Start this patient on antibiotics, and I would get a PET CT if available at the institution. The increased FDG avidity won't distinguish between infection and cancer, but if we see stuff light up in specific areas, it may further strengthen that hypothesis. So I think now that I'm thinking out loud, it'll be very difficult to distinguish the two. But our greatest concern is some form of ectopic Cushing's from either a small cell lung cancer or, pancreatic neuroendocrine tumor or a bronchial cancer, leading to a suppressed immune system, making them vulnerable to infections that are increased in patients with impaired cellular immunity. Start Bactrim, do a BAL, and search for that cancer. Oh, the BAL was negative. Oh, I hate when this happens to me. I really do. Oh, Robbie, you got to tell me this stuff sooner. Or someone unmute themselves when I go on. Oh, the culture is negative. Thank you, David. So this brings us back to a new frame. But the elevated LDH, I think the culture is one thing. The sensitivity does increase, but you do want the silver stain, you do want the PCR, you do want the fluorescent antibody, and causes of elevated LDH go from cancers, like liquid cancers like lymphoma, and you have to think about metastatic adenocarcinomas as well. Cancer gets increased, but in any case, those would be my next steps and workup. So maybe the BAL being negative and the hypercortisolism that's on board isn't really treating if it were PJP. But nevertheless, I'll leave it at that until we get some more data.
Okay, so the PCR for PJP was positive. It was also positive, the PCR for CMV in bowel, but not the PCR in blood, but we treated for both infections. And it was, we then checked the CT with the radiologist, and because the centrilobular emphysema was not very concordant with his absence of smoking history, and they thought they could be hematocele for PJP. And well, it was a beautiful case because despite the high-grade hypoxemia, he tolerated very well the hypoxemia. He barely has any dyspnea, and we thought this was because of the high steroid in his blood. And thank you very much because you take it very well again.
David, what a case. So the final diagnosis was CMV pneumonitis?
Was PJP and CMV was both of them.
PJP and CMV.
Yeah.
Thank you. You saved my entire confidence in this case. But I have to say one thing really quickly. First of all, David, thank you for presenting this case so expertly. Well done. You have to be, with CMV, it's a very tricky organism because it's one of those organisms like EBV that exists in many of us. And when we get ill, it reactivates and you might see it in the blood. So it's not a straightforward diagnosis. So whenever you see CMV, you have to ask the question, is this syndrome compatible with CMV? And here, it's not so much in the blood that we detected it, though I would be interested in the CMV PCR levels. We detected it in the tissue, and that's how you make the diagnosis. You got to show that the CMV is actually causing problems to the tissue. So for example, in the GI tract, if someone has diarrhea, you want to biopsy and show the CMV organism. And the treatment for that, I believe, is ganciclovir. I wonder if that's what this patient received. In any case, I just want to end it with this before giving the mic to Robbie. This like comes up over and over again. When your immune system is very vulnerable, don't just look for one infection. Don't just look for one infection. And I think that for me, one of the highlights was the Robbie's sort of approach to ground glass opacities and infections, because he said PJP, virus like CMV, and mycobacterial disease. And this patient had 2 of those 3 findings contributing to the ground glass opacity. We hope you enjoyed. Robbie, to you before we go to our wonderful Shema.
Oh, Professor, I couldn't agree more with your reflection. And David, I don't know if you realize just how much learning and teaching you brought to us today, including a lot of bread and butter stuff. But I think this case, since we have a couple minutes, I'll just make a couple of very maybe helpful points. I think the first is, this is not an uncommon scenario in patients with ectopic Cushing's. Poor Prof. Rez and I have had to sit through many a case of ectopic Cushing, and so as a result have read about it and learned that about 20% of patients with ectopic Cushing's don't have an obvious cause of their ectopic and may remain undiagnosed for years. So the cancer may emerge subsequently. So just because you haven't found an ectopic now doesn't mean it wasn't there, and it may emerge later in 20% of patients. The other thing is that, honestly, I misinterpreted what you said about the BAL. I thought you said the BAL was all negative. And so let's pretend that was the case. If the BAL, even for PJP, was negative in this scenario, it still is probably PJP. And let me explain why. The amount of PJP bug in the lungs is a function of the host. In patients with HIV, the negative predictive value of PJP PCR in the BAL is very high because they have a lot of organism. In non-HIV related PJP, the PCR can be negative in up to 20% of patients. So just like TB, in non-HIV related PJP, the only option sometimes is response to treatment. So just know, even if David said all the BAL is negative, PJP is not off the table in a case like this. And then the final point is, CMV often exists in the lungs with 2 other infections, and it's PJP and Aspergillus. So it's not surprising when you see PJP and CMV together. And the other infection that you should think about if this patient doesn't get better is, do they also have Aspergillus? There's some connection and overlap between these organisms that I don't understand, but worth looking into. So the final result of PJP plus CMV is not surprising because of the steroids, but also because of this relationship that PJP and CMV have. So there's so much bread and butter here, and there's also a lot of gourmet. And so I enjoyed this great cognitive feast with you, David, and really appreciate your time. And your English is perfect. I just made an assumption. You said BAL is negative, and I assumed. So you don't apologize for your English. Your English is way better than any other language I speak, except French with Prof. Rez, where my skills are okay. All right, Shema.
I thought you were going to say it's way better than Prof. Rez's French.
No way.
That's so
Never.
true.
Never. All right, Shema, take us home, please.
So hello, everyone. Thank you so much for this amazing case, David, and also RLR. Amazing discussion. The chat was also on fire. I will start with some quick teaching points. So we had back pain as one of the chief complaints. And in 95% of the causes, the cause is actually non-specific. So musculoskeletal strain. And the most important thing is to see whether we have some red flags, like signs of inflammation, some focal neurologic deficit, or some history of cancer, trauma, urinary incontinence, or stool incontinence. And then we come, and also saddle anesthesia. And then we had a severe hypokalemia, which was our focus here, because this is leading to the morbidity in this case. So if you have potassium below 3, you usually treat before you diagnose, because we know the potassium is, as Reza said, important for the cellular function, for the depolarization contraction of the myocardial cells. So what we actually do is to do the telemetry, to look in the EKG whether we have a prolonged QTC, some torsades, and also we always check the magnesium, because the normal magnesium levels prevents the kidney from excreting potassium. And we also give IV potassium. And the etiology for severe hypokalemia, there are multiple causes like GI loss from the kidney, cellular shift like an alkalosis, and also other things like insulin intake or renal tubular acidosis type 1 and 2. And the other explanation for if we have like GI losses, the explanation for for hypokalemia is basically if we vomit or have diarrhea or generally volume contraction, it leads to the activation of the renin, angiotensin, aldosterone system. And as we know, aldosterone leads to the potassium excretion. And now coming to Cushing syndrome, we think of 3 causes. So the thing is it exogenous or iatrogenic, like the intake of steroids, which is very common? Is it a pituitary cause? Or do we have some ectopic Cushing syndrome, which is the cause in 15% of cases? And we had severe hypokalemia, and we learned from Ravi that we should then prioritize an ectopic source. And the most common causes for ectopic Cushing syndromes are aggressive thoracic diseases like small cell lung cancer or bronchiogenic cancer, and in abdominal cases like pheochromocytoma or other neuroendocrine tumors, or also, as we learned, that some advanced prostate cancer can also differentiate into a neuroendocrine tumor. And then we had high ACTH, and the things that can cause it are, is it pituitary or ectopic Cushing syndrome? And then now coming to the high ferritin in this case, we had several differentials like Still's disease, hemochromatosis, inflammation, which was the case here, or something like HLH. And now trying to put the framework in this case, the hypoxemia, the bilateral crackles, and the excessive steroids due to its Cushing, we were prioritizing infections like PJP or atypical bacteria. And then we had ground glass opacities. And as we know, think of pus, blood, water, and inflammatory cells. And what we also learned is to think of viruses like COVID, CMV, and also think of PJP, like we think of PJP if we have high LDH, and in this case, we would start empiric bacterium treatment. Yeah, and then we had a co-infection of PJP and CMV, and we also learned that if we have CMV infection, always think of Aspergillus and PJP2. So it's not rare that we can have CMV and concomitant PJP infection. So thank you so much for this amazing case. Yeah, hope to see you again.
Can I make a quick comment? Your teaching is just unbelievable. Like not only do you teach what we taught, but you take it to the next level. Like I didn't mention anything about ENAC, but I see ENAC is there. So like listening to you speak, just really superb. I can't wait to see your future, Shema. Thank you.
Thanks, David. Thanks, Prof. Rez. Thank you, Shema. A real treat. Hope to see you all next week. Just in case you're a regular RLR consumer, we're also going to be at 8 at this time next week for the next couple of weeks. Okay. So hope to see you then. Bye.